Welcome to Pathology Peoples. Today's topic of discussion is PNH. We will discuss pathogenesis, clinical features and diagnosis in few minutes in interesting way. It is very important topic for NEET PG and pathology postgraduates. If you like the people, kindly subscribe the channel for more such peoples. You can increase the speed as per your convenience. Starting with etiological classification of anemia. Anemia is divided into the anemia due to the impaired red cell production or anemia due to the increased red cell destruction. It is again divided into the intracorpuscular defect and extracorpuscular defect. So as we already discussed, hereditary enzyme deficiency is G6PD deficiency while acquired enzyme deficiency is PNH. G6PD video link given below. Starting with PNH, PNH is a disease of the hematopoietic stem cells. Therefore, beside hemolytic anemia, there will be element of the bone marrow failure. So there will be either aplastic anemia, myelodysplastic syndrome or pancytopenia. Starting with pathophysiology, there is an acquired mutation in PIGA gene located on the X chromosome. So there will be deficiency of the GPI-anchored protein. It is seen in a neutrophil, monocyte, platelet and lymphocyte. So there will be pancytopenia, neutropenia or thrombopenia in combination with anemia. Now moving on to the PIGA gene. PIGA gene is a phosphatidyl inositol glycan class A gene. It is a gene which encodes an enzyme which is essential for component of the glycosyl phosphatidyl inositol. So it is a GPI anchor. This GPI anchor is important as it expressed 20 proteins like DEF and MIRL. It prevents lysis by the complement. Before moving forward, we will understand the complement pathway. So as we all know, there is classical lectin and alternative pathway. The derivative is C3 convertase, which convert into the C5 convertase, and terminal pathway is membrane-atic complex, which is C5 to C9. So there is two, DEF and MIR, decay accelerating factor and membrane inhibitor of reactive lysis. So CD55, it inhibits the C3 convertase, and CD59, it inhibits the C5 to C9 complex, and it induces the complement-mediated lysis. So there will be hemoglobinuria, complement-mediated activation of platelets. So platelet will be full and neutrophil will decrease. So there will be eventually pancytopenia. Clinical features, it is seen in 40 to 50 years of age, and there will be nocturnal hemoglobinuria. Patient wake up with cola colored urine, but it eventually disappears as a day passes. What are the other clinical features and complications related to the intravascular hemolysis? There will be anemia, hemoglobinuria, jaundice, fatigue and chronic renal failure. There will be thrombophilia, so venous thrombosis and arterial thrombosis will be seen. And due to the bone marrow failure, pancytopenia, MDS and AML will be seen. What is the laboratory finding? So there will be macrocytic or microcytic hypochromic anemia with moderate anisopoikilocytosis. DCT will be negative. So the image is showing anisopoikilocytosis with presence of elliptocyte teardrop cells and RBCs. Urine will show increased urobilinogen, hemoglobinuria and hemosideruria. So it is the features of intravascular hemolysis. Now in serological tests, due to the intravascular hemolysis, there will be serum heptoglobin decrease, indirect bilirubin and IDH will increase. In bone marrow, there will be normoblastic hyperplasia, megakaryocyte decrease and hypoplastic marrow due to the ineffective hematopoiesis. The image is showing normoblastic erythroid hyperplasia. Now starting with diagnostic tests. So there is two type of tests based on the abnormal complement lysis, hem test and sucrose lysis test, while based on the recognition of GPI anchored protein deficiency, there will be cephacry gel card test, flow cytometry and FLAIR. We will see one by one. Starting with hem test, it is also known as acidified serum lysis test. Name itself suggests the procedure. Principle is complement added to the RBC at acidic pH. So patient's RBC are exposed to the 37 Celsius or patient on serum acidified to the optimum pH. PNH RBCs are sensitive. So in this image showing normal healthy donor erythrocytes are not hemolyzed, while erythrocytes of the patient with PNH is lysed at acidified serum. So first test to be showing intact serum. So PNH red cells do not lyse, while they lyse in acidified serum. do not lyse in heated serum at 56 Celsius. Now, moving on to the second test, it is a sucrose lysis test. It is also known as a sugar water test of Hartmann. Principle is red cell absorb the complement component from serum at low ionic concentration. PNH cells, because of their great sensitivity, undergo lysis, but normal red cells do not. So we have to take isoosmotic solution of the sucrose, which provide a medium of low ionic strength. So, as the image shows, there is a red cell suspension of patient, controls serum and sucrose. Isoosmotic solution of sucrose provide a low ionic strength and it will increase the binding of complement to RBC. So if there is a PNH, there will be hemolysis. But there is a disadvantage. False positive will be seen in other blood cell disorders like myelodysplastic anemia and deficiency. And false negative will be in recent BT. Moving on to the cephacryl gel card test. So there is a demonstrating button at bottom indicating lack of DEF and MIL antigen on red cell surface in tube 4 and 5, confirming the PNH. It is the best test to diagnose. It is a confirmatory test. In patient of PNH, the cell lacked CD55 and CD59, so it will not agglutinate and pellet will be at form at bottom. While if there is no patient with no PNH, clump will be on top, so there will be CD55 and CD59 and it will agglutinate. Now moving on to the flow cytometry. In flow cytometry, patient red cells are stained with fluorescent antibodies specific to the GPI-linked protein CD55 and CD59, which are deficient in PNH red cells. CD59 is highly expressed on RBCs, therefore more commonly used. Lifespan of GPI-anchored protein deficient RBCs is greatly shortened, therefore this deficient PMN give accurate reflection of PNH mutant clone. So in flow cytometric image, as there is on x-axis CD59 and y-axis CD55. So PNH clone in 26% of cells, while normal granulocytes 74%, showing the normal CD55 and CD59 expression. Now moving on to the last test, it is a FLAIR fluorescent aerolysin test. It utilizes the fluorescent labeled inactive variant of the protein aerolysin. It is a toxin of bacterium Aeromonas hydrophilia. This reagent can only detect leukocyte with PNH phenotype, not RBCs. This was all the diagnostic test of the PNH with intravascular hemolysis. PNH can be difficult to manage, but in subclinical PNH, there is no specific treatment. While if there is a bone marrow failure syndrome, it should be treated with eculizumab, splenectomy, and supportive care as per required. So this was all about the PNH. Thanks for watching.